Hello, everybody. It's indeed a pleasure to be here. And I thank Dr. Yogan for giving me this opportunity. Next 20 minutes or so, I'm going to talk about how to manage DIC in sepsis. I have no declarations, no conflict of interest. I bring you greetings from Medanta, the Medicity, large tertiary hospital outside New Delhi, India. So why are we so concerned, particularly about sepsis and DIC? Because the problem is humongous. 2017, about 50 million sepsis cases happened, and one fourth of them died. So the mortality is humongous even in the Western countries. So you can imagine what would be happening in the developing countries. So basically, when the body is attacked by whatever pathogen, mostly bacterial pathogens, then the PAMs, pathogen-associated molecular patterns, which produce injury to the body, and the various cellular elements release damage-associated molecular patterns, nuclear chemokines, and so on. Lymphocytes and neutrophils get activated, macrophages get activated, there's a dysregulated host response, coagulation get activated, complement system, cytokines are released, and so on. So, as I said, the bacterial invasion leads to activation of the cellular elements. Factor 7 can also be released, and pro-inflammatory cytokines are released. Platelets can get activated, and there is microvascular thrombosis. Extrinsic tissue pathways, coagulation pathways get activated because of tissue factor release. Also, cellular apoptosis happens, endothelial permeability changes, endothelial damage happens, and fibrinolysis is reduced. And on one hand, there is thrombin generation and leading to fibrin formation and microvascular thrombosis. So on one hand, you have, because of platelet aggregation endothelial dysfunction, you have microvascular and procoagulant pathways are activated. You get microvascular thrombi. On the other hand, anticoagulation system is down-regulated. That is, fibrinolysis is suppressed. So infection and inflammation, endothelial dysfunction, nitric oxide is reduced. Prostacyclin is also reduced. Von Willebrand factor and tissue factors are increased, and there is a loss of glycocalyx. So inflammatory markers and thrombin get attached to the platelets, which get activated, release serotonin, DAMPs, and ADP, and they aggregate. So there is a down-regulation of anticoagulation mechanism. Glycocalyx is disrupted, and the normal endothelium, which produces multiple antithrombogenic molecules like nitric oxide, prostaglandin I, thrombomodulin, and so on, they are reduced. And therefore, prothrombotic activity increases on one hand, and antithrombotic or fibrinolytic activity decreases. So antithrombin provides 80% of activity against thrombin. It inhibits several coagulation factors, binds glycocalyx on the endothelium, and protects endothelium and is antithrombogenic. So the consumption of antithrombin happens, extravasation of this happens, impaired production on the other hand, and its degradation by neutrophil elastase ultimately leads to decreased antithrombin. And as I said, fibrinolysis is reduced. There is sustained increase in plasminogen activator inhibitor 1, which has been observed in sepsis, and tissue plasminogen activator and urokinase and PAI are all endothelium plays a very important role, and which is inhibited. So tissue plasminogen activator is reduced, and plasminogen activator inhibitor is increased. So fibrinolytic shutdown happens, and initially there is a microthrombi formation. So our normals could now what is the main problem? Japanese Society and ISTH, International Society of Thrombosis and Hematology, it said that the SIC, that is sepsis-induced coagulopathy, happens in 30 to 60% of sepsis, and it is significantly higher mortality. So what is the role of DIC in severe sepsis? Well, these are sicker patients of sepsis. They have more multi-organ dysfunction syndrome, and They are sicker patients. Because of that, they have longer ICU hospital stay and mortality. As you can see here, that if you look at the severity scoring, that is SOFA score is the commonest one which is used, platelet count plays an important role in SOFA scoring. So again, systemic activation of coagulation leads to intravascular deposition of fibrin, thrombosis of small and mid-sized vessels, which leads to reduced perfusion and organ failure. And on the other hand, you may have other extreme with platelet and coagulation factor depletion, leading to classic DIC. So what is the differentiating features of non-septic DIC and septic DIC? Fibrinolysis suppression is greater in septic DIC. Overproduction of plasminogen is also greater in septic DIC. Organ dysfunction is more, and hypofibrinogenemia is not so common in septic DIC. So in this, you can see on one hand you have coagulation, which is SIC. On the other hand, you have fibrinolysis, and you may have consumption coagulopathy, which can lead to massive bleeding. So this is on one hand you have thrombotic phenotype, on the other hand you have bleeding phenotype, and this is so initially the prothrombotic state, later on as depletion and platelet counts go down, there is more of bleeding. So you can have a thrombotic phenotype and fibrinolytic phenotype, as you can see this. Okay. Now there is a scoring system which has been evolved for septic SIC. So these are the points in this, and SIC is diagnosed if total score is 4 or more, with prothrombin time and coagulation exceeding 2. So these are the differentiating features between DIC score and SIC score. So total SIC score is more than 4, then it is considered SIC. DIC, it would take a longer time to diagnose SIC. So this score has a sensitivity twice as much as of overt DIC scoring. It is important that this is because of, if you use this SIC score, the diagnosis is earlier, and earlier diagnosis, ISTH is recommended, leads to better outcome. And one of the ways of diagnosing this early is by viscoelastic testing, maybe thromboelastography, which is TEG, or rotational thromboelastometry, which is ROTEM. There's fundamental differences between the two, but basically both are viscoelastic testing. In TEG, there's a cup and a pin. The cup rotates in TEG while the pin rotates in ROTEM, so which both measure basically the strength of the clot formation. So this will tell you where the clot lies in the whole coagulation system, including the fibrinolytic system. So this was a Japanese paper, TEG in the monitoring of coagulation. So what happens in septic shock group, R value and K time was significantly increased. Lysis 30 was also increased, while MA value, which looks at the clot strength and coagulation index in ROTEM, and alpha L was significantly decreased. So the clot is weaker to begin with. With increasing of SOFA scores, that means patient becomes more severe, R value and K value increase significantly, and alpha angle MA value and CI decrease significantly. So ROTEM has been found to have a sensitivity of 100% and specificity of 83%, although in this paper the sample size was small. Another paper, hypercoagulability profile was seen with ROTEM for early detection of sepsis, and the severity dependent on the degree of hypocoagulability. What does the British Journal of Hematology say? British guidelines say main treatment is treatment of DIC, the treatment of underlying condition. This is grade C level 4 recommendation. How does one manage SIC? Well, you treat the underlying cause, supportive measures, that means hemodynamic support, organ support, and transfusion when indicated. Heparin is the commonest agent used. There were several studies earlier which showed uncontrolled studies showed that low molecular weight heparin is capable of improving abnormalities. Levi et al. From the US, large trial in patients with severe sepsis showed no significant benefit. And other paper, hit race study 2009, there was no survival benefit. Two RCTs compared heparin versus other anticoagulants. Thrombomodulin showed a mortality of 21% compared to 31% in heparin group. Three specific populations with sepsis, they compared meta-analysis of large number of 9 trials, significant reduction in mortality in the population with SIC. And sicker the patient, better the result of anticoagulation. In this again paper, Chinese paper, low molecular weight heparin significantly reduced PT and Apache 2 scores and 28-day mortality, but significantly higher bleeding events. Some of the newer agents, thrombomodulin, it binds reversibility to anion binding exocyte of the thrombin, interrupting the binding of thrombin to its coagulant substrate. It provides the binding surface of protein C. It also has anti-inflammatory effects. So this was a Japanese paper. It was invented in Japan. Subgroup analysis in this paper with SIC revealed a reduction in absolute mortality by 11%. This was a randomized controlled trial in many countries, 233 ICUs in 17 countries, John Louis Vasa's group, and positive effect if the patient's PT ratio or INR was greater than 1.4. So it supported the use of thrombomodulin. And this was a negative paper, Japanese again, not associated with reduction in mortality. Another paper, thrombomodulin meta-analysis, reported a reduction of the mortality by 13%. Another agent which has been used, which is synthesized by the liver, is antithrombin. It inactivates several coagulation factors, and plasma levels of antithrombin have been shown to be low in sepsis and it's predictor of outcome. So in this paper, randomized controlled trial, high dose antithrombin 3 did not affect 28-day mortality. But the negative side of the study was done in all septic patients, irrespective whether they had SIC or not. So this was another meta-analysis, compared the 3 anticoagulants versus placebo. No significant differences between antithrombin, thrombomodulin, or heparin. But antithrombin was associated with a 5-fold higher likelihood of DIC resolution. The Japanese Society of Thrombosis and Clinical Practice Guidelines suggests the use of antithrombin replacement therapy in patients with SIC if the antithrombin activity has decreased to less than 70%. Now, this Japan obviously has, all the hospitals have antithrombin 3 measurement facilities, and also antithrombin 3 is available in Japan. So some of the developing countries may have antithrombin 3, but otherwise many of them do not have. Recombinant activated protein C became very fashionable for quite a while. In sepsis as such, it is supposed to prevent microvascular thrombosis, but the PROVEST trial was negative, so it was not recommended and stopped. Again, recombinant tissue factor pathway inhibitor. It's a serine protease inhibitor, modulates the coagulation system, and tissue factor plays an important role in DIC generation. So this paper published in JAMA, Reinhardt's group from Germany, with no effect on all-cause mortality with severe sepsis and high INR. So tifacoguin administration was associated with increase in risk of bleeding. Again, another paper, greater reduction in PT and thrombin-antithrombin complex levels related to baseline, and post-hoc analysis suggested a trend towards improvement of survival. This was in community-acquired pneumonia patients. So what are the recommendations? Well, unfractionated heparin or low molecular weight heparin, recommendation is none for DIC except for DVT prevention and treatment. Antithrombin 3, if it is available, some societies do recommend it. Thrombomodulin, again, more evidence is required. Scarlet study did not show any efficacy. So the American Society of Hematology, this is the algorithm. If they have clinical suspicion of sepsis on a quick SOFA, coagulation screen and D-dimer should be done. You look at the DIC score or SIC score. If the score is more than 5, then treat it as DIC. You treat the obviously underlying sepsis. If there is active bleeding, you can give tranexamic acid or vitamin K or FFP or platelet transfusion. And PCC if it is available in your country, 3-factor or 4-factor. If there is no active bleeding, then you just give thromboprophylaxis with low molecular weight heparin. And if there is thrombosis, then obviously you have to treat it accordingly. So tranexamic acid or epsilon aminocaproic acid is recommended with this acute bleeding. 1 gram 3 times a day, either IV or PO. RBCs if there's severe anemia, less than 7 gram%. Vitamin K if the PT is prolonged. FFP or cryo if you have, or octaplex if you don't want to give too much of volume, that is factor 3 or 4 PCC, prothrombin complex concentrate, if the prolonged APTT or PT are there. And then cryoprecipitate or fibrinogen concentrate if you are available, if fibrinogen has been demonstrated to be low. Low is less than maybe 1 gram. And platelet transfusion, I'll come to that later. So when does one transfuse platelets? If the platelets are less than 10,000, that is risk of spontaneous bleeding. If you're planning to do a procedure, then platelet count should be more than 50,000. FFP or cryo, if APTT or PT are more than 1.5, and plasma fibrinogen less than 100. So these are the various recommendations. This is the British Society, this is Japanese Society, this is ISTH. Unfractionated heparin, recommended. Prophylaxis for VT, recommended. Low molecular weight heparin, not recommended. Referred to unfractionated heparin. Activated potency, recommended, but needs further study according to ISTH. AT and thrombomodulin, again, recommendations need further studies, but Japanese Society recommends AT, antithrombin. Plasma exchange, no role to play, and antifibrinolytic agents recommended by British Society and ISTH. But you have to rule out differential diagnosis of coagulopathy. There can be multiple other reasons which have to be ruled out. So basically, coagulopathy is a very important component of sepsis-related morbidity and mortality. Early recognition of the coagulation disorder, prompt initiation of targeted anticoagulant therapy may alter outcomes of sepsis. But early and rapid diagnosis is important for this therapeutic consideration. Targeted therapy using precision medicine, namely anticoagulants, is an important consideration in sepsis. So thank you very much for your attention.